Hello, I am Kelly Miners and I'm here to present on cerebral vascular accidents for our NU 62 Advanced Pharmacology and Pathophysiology class. My presenting patient is a 55-year-old female that came to the ED. She came to the ED from the gym where she collapsed on the treadmill, telling her friend that she had the worst headache of her life. She had a positive loss of consciousness a few minutes after she collapsed. She was brought in by the ambulance and came to the ED. Her friend said that she has a past medical history of hypertension and smoking. Her family is not present and the patient is not conscious, so the rest of the history has been deferred. When she came into the ED, tests were immediately done. A drug screen was done and that was negative. Labs were drawn. Her INR is 1.0. Her hemoglobin is 13. Her hematocrit's 40% and platelets were 150. She had a sodium of 136 and a potassium of 3.7. Her initial vital signs were blood pressure 190 over 75, heart rate 128, respiratory rate 24, temperature 98.8 degrees Fahrenheit. She is 5'5", 168 pounds, and her BMI is 28. She was immediately taken to do a CT of her head and then a CTA. The CT of her head showed hydrocephalus, and they showed some blood that was deep by the circle of Willis and a fair amount of edema. In the CTA, when they did that, they showed a big aneurysm that they could see on that right at the basilar artery at the bifurcation. They went on to finish their clinical assessment, and the clinical assessment showed that she had a Glasgow Coma scale of 5. She got 1 for eye opening because she did not open her eyes at all, 1 for verbal because she is not speaking at all, and a 3 for movement. Her right pupil is dilated, her left pupil is 3 and reactive to light. She has a positive cough, she has a positive gag, she has right upper extremity posturing, left upper extremity withdraws to pain, and bilateral lower extremities postures with pain. Cardiac-wise, she is in a sinus tachycardia with frequent PVCs. There's no murmur heard. She has 3+ radial and pedal pulses. Her lungs are clear to auscultation. She has positive bowel sounds, and a Foley catheter was placed with clear yellow urine obtained. She has some bruising on her right upper leg and her right shoulder from falling off the treadmill. The diagnosis is a hemorrhagic stroke from a subarachnoid hemorrhage. With subarachnoid hemorrhages, they use a scale called a Hunt and Hess scale, and that is a predictor of a 30-day mortality. And the higher the number, the worse it is. And it's based on the presenting symptoms of when the event occurred. So with her event occurring and her first assessment in the ED was that she's stuporous, that she had some moderate hematopoiesis, she would be scored a 4. So that 30-day mortality would be fairly high. So again, her diagnosis is a hemorrhagic stroke from a subarachnoid hemorrhage, more than likely at the basilar artery. So the reasons this occur is when you have hypertension, as that blood is pounding against those vessels, it can weaken the vessel wall. Smoking will also weaken that vessel wall. Also, perimenopausal women will have a hard time with it will start to change their vessels, and aneurysms are a lot more common with perimenopausal women. So if you can see that picture is the circle of Willis and it's the basilar artery, you have your carotid arteries coming up to your basilar artery, and then they bifurcate out to the posterior cerebral arteries and the posterior communicating artery. So right where that splits if you have very high blood pressure, like starting to hit that all the time, it can weaken that wall and something can set it up. And sometimes it's with exertion, sometimes it's with sneezing, sometimes it's a lot of those different things as that blood pressure goes up a little bit higher. So your blood vessel is ruptured and bleeding into the brain occurs. So your brain is a very closed box system, and that's where the Monroe-Kelly doctrine comes from. You have a skull that circles your brain, and it doesn't. Bone does not give like tissue can give, and you can. There's only so much brain. Only so much CSF and so much blood that you have room for in that brain. If you get more of one or the other, your body tries to compensate to make up for that. And if it cannot compensate, then brain tissue starts to die. So a blood vessel is ruptured, bleeding occurs. Generally, that bleeding will tampen on itself off rather quickly, but you will, you do edema and do that extra those that occupy the mass that occupies the space, you will have decreased blood flow. When you have decreased blood flow, you have hypoperfusion to the brain, and you can have tissue death. That will come from the edema, which can cause hypoperfusion, and also hydrocephalus. Your CSF is made and it's reabsorbed in the subarachnoid space. So when it cannot reabsorb that, your ventricles will increase with backup of CSF, and that puts more pressure on the brain, and that can cause more cell death. The main treatment for patients that come into the hospital with this kind of diagnosis is to secure the aneurysm. First thing you want to do is get the blood pressure down, secure the aneurysm, and then we'll try and prevent secondary injury. To secure the aneurysm, you can do a coiling, you can do a clipping, and sometimes they'll put in stents too. So it depends on kind of where the aneurysm is, if the institution has the ability to do these procedures or not as well. A lot of times coiling is less invasive. They can go up to like a cardiac catheterization and put in a substance almost like dental floss where it kind of like molds into the aneurysm and secures the aneurysm. Once the aneurysm is secured, your main goal is to prevent a secondary injury. Secondary injury will come from the tissue hypoxia. The tissue hypoxia will come from vasospasms, increased edema, from just tissue edema, or even hydrocephalus occupying more space. And if they're not getting enough oxygen up to the brain, by they're not breathing well enough, you're not getting enough oxygen into their lungs to get up to the brain, or if they're having seizures or anything like that. So to treat hydrocephalus, you can place an EVD to help mechanically drain the CSF, and that will help decrease the space that it's occupying. You can also monitor ICP and CPP, which is cerebral perfusion pressure, to determine if you're getting enough oxygen to the brain to help prevent a secondary injury. Vasospasms are when that blood irritates the outlying of the outlying tissue of the arteries that are in there, and what they do is they clamp down. And as they clamp down, then you get tissue hypoxia because you can't get any blood flow up there. So you try and keep the patient euvolemic so that their vessels are full enough so they can't clamp down all the way. And calcium channel blockers in the form of Nemotop are given. It's a smooth muscle relaxer to help with the cerebral vessels, help decrease spasming and the worsening of spasming. There's also tests like transcranial Dopplers that will be done to help read the velocity of the vessels, and the higher velocity, the smaller the diameter, and that could be that they're starting to spasm down. Sometimes they'll go back to interventional radiology to give medications to help open the vessels that way as well. Seizure prophylaxis is a little controversial with these patients. It's not done initially, so they will kind of wait and see if they feel like the patient's having seizures. Sometimes EEGs are done to look for subclinical seizures when the patient's intubated and on the ventilator. Also, serial sodium and potassiums are done. There could be a neuroendocrine functioning with edema on the brain, especially when it's that deep and you're close to the hypothalamus. and even pituitary. And so a lot of patients will go into cerebral salt wasting, and so that they'll lose a lot of their sodium, and they'll have more edema. And we want less edema because we don't want that much space in the brain. So we'll make sure that you check their sodiums quite frequently, and run the sodium on the higher side so they will get dehydrated a little bit and decrease that edema. So once a patient has an aneurysm, it gets fixed. You get them through those first couple of weeks of all those complications, and then you can start to think about rehabbing them. Stroke rehab is very, very important for these patients. The sooner you can get them in, the better. Uh, there's a lot of neuroplasticity and motor skill that you can relearn through rehab, and been great things that have happened with this in order to get a lot of people's functioning back. Some patients will have a lot of speech and cognitive therapy as well. It all depends on what vessel was occurred and where that tissue had died and gotten ischemic. Also, families and the patient themselves will need a lot of support groups and therapies. Depression is very, very common. Their lives have completely changed in a blink of an eye, and they're not able to do a lot of the things they were done before. So it takes a lot of resources to help support the family through all of this. Here are my references. I found a lot of great references to help support all of this, and I hope you enjoyed my presentation. Thank you.